you who don't know me, I'm Helen, the speech therapist, and Linda, the dietitian. So we're just going to go through this afternoon about dysphagia, about food and fluid textures, malnutrition, tips for feeding, that type of thing. So if you have any questions along the way, please feel free just to stop and ask us as we go. So we're going to go through what is dysphagia, the incidence of dysphagia, signs of it, aspiration, the food and fluid consistencies, and then safe feeding and swallowing techniques for if you're feeding residents here. So dysphagia is a difficulty with swallowing food or fluids. Early detection of dysphagia in patients with acute CVAs or strokes reduces their risk of pulmonary complications, and it can also reduce their length of stay in hospital and, as a result, overall health expenditures. Swallowing difficulties affect as many as 22% of people as young as the age of 50 and over. So that's quite a big percentage when you think of that, how many people are in that age range. This increases to approximately 50% of people living in residential aged care facilities. And I think Linda will later tell you that here it's something like 38-39% of people who are on different consistencies. Minor changes or difficulties with swallowing is a normal part of ageing. So some people just get older and have difficulty swallowing. Others might get particularly sick, they might have bronchitis or a UTI, go to the hospital, they're quite unwell, or they could be delirious. They often get changed down to a lower diet while they're in hospital. Then they come back and in a week or two they're feeling a lot better. Sometimes they get reviewed, sometimes they don't. So some people are stuck on, say, pureed or instilled moisture for a long time without being, checked again and upgraded. So it's important, usually they'll stay from a hospital, to check them again when they come back, and hopefully by that stage they can get back to their baseline. Dysphagia can be caused by many things, so CVAs or strokes, Parkinson's disease, dementia, cancer, motor neurone disease, a whole list of things basically. Following a stroke, the swallow recovery is the quickest in the first 3 weeks after the stroke. So we try and get in there as soon as they've had their stroke, and if there's any exercises that can be done to help the patient, we try and do those within those first couple of weeks while they're still an inpatient at hospital. Approximately 60% of patients who have had a stroke will have swallowing difficulties, so whether it's on food, fluids or both. And aspiration is a big risk of dysphagia. So aspiration is when food or liquid goes past the level of your vocal cords and down towards your lungs, so it can end up as pneumonia. So your vocal cords close together when you're swallowing to prevent food going into your airway. Particularly patients whose voice has been affected, one vocal cord might be paralysed, so they're more at risk of it going down the wrong way. So that just acts as a protective mechanism. The complications of dysphagia, again, Linda will talk about malnutrition later, which is a big one. Dehydration, particularly if they're on thickened fluids. A lot of people hate the thickened fluids, so they're drinking less, which is a big issue, particularly in summertime. I did have one man once, he used to get his drinks from DBA, his thickened drinks, and I said to him, "Do you go through a lot of these?" He said, "Oh, my son likes to drink them." Okay. So he was drinking all his thickened fluids and having to reorder all the time. So first person who likes thickened fluids, I think. There's an increased risk of chest infections and, as I said, aspiration pneumonia, which can lead to a longer length of stay. Often they have to discharge to a nursing home, particularly if they're not capable. You have some old people who aren't capable of blending up their food or making up the drinks themselves in their own home, and unfortunately a higher mortality rate. As a result, bigger financial costs because of their longer length of stay in hospital, more antibiotics needed if they do get a chest infection, and x-rays need to be taken frequently to see if it's improving, worsening, increased nursing time, particularly if they're needing to be fed, and increased physician consults, so they're regularly checking on the patient daily to see how they're going with those issues. Signs of dysphagia to look out for are throat clearing, so it might just be if they're having a drink or some from food might just be as simple as just that regular constant throat clearing. It doesn't have to be overt coughing or choking. Then there is the coughing and choking. If they become short of breath during their meals, so they might take quite a long time to chew their food, by the time they've swallowed it, they're sort of... So see if you can encourage them to not have any more until their breath gets back to that normal sort of rate, because they're at higher risk of, breathing in while they've got something in their mouth and inhaling it or, causing aspiration. Difficulty in manoeuvring food around the mouth, so if their lips or tongue muscles are weak from, say, a stroke or Parkinson's or motor neuron disease, they have a lot more trouble trying to get that food moving around in their mouth the way that we just normally do it without even thinking. Food residue left in the mouth, so a lot of people, again with the stroke, they have less feeling on one side, and so they can, sometimes you can have people with a cheek full of food and they just can't feel it there. So that can be a big issue. Try and get them to eat on their stronger side, so if they do have a weakness on one side, if you're feeding them, put the food into the stronger side, or ask them to chew on that stronger side. People spitting out lumps of their food, sometimes it can even occasionally, with a puree or minced and moist, and they're spitting out the tiniest of little lumps that you wouldn't even think would be an issue, but a lot of people do that. And then dribbling or spillage of food from the mouth or drinks when they're drinking. Aspiration. Now, of the people with dysphagia, about 40% are classed as silent aspirators. So if you or I have a drink and it goes down the wrong way, you have that huge cough where it feels awful and you're trying to get it back up. 40% of people with the issue, nothing happens, so they don't get any signal that it's gone down the wrong way. They don't gag, they don't cough, they just swallow and think everything's fine. Unfortunately, there's no way that we can diagnose that just by assessing them, here. It has to be done by a bearing swallow or a video fluoroscopy where it's, videotaped on X-ray and you can actually see it going down the wrong way and they've had no reaction whatsoever. The things that we can look out for here are high temperatures for no particular reason, a change in their chest status or a chest infection. So they're the sort of signs to look out for. Somebody could be aspirating without any clear signs being shown. Okay, going to move on to the food consistencies. So the normal diet, all foods are allowed. There's absolutely no restrictions for them. The easy to chew diet, level 7, includes, sorry.
Do you need a second through?
My fault, thank you. Normal everyday foods of a softer or tender texture. Extra sauce or gravy is often helpful. No restriction on the side of the food, so they can have a piece of chicken or a piece of pork or lamb, whatever it might be. And they are allowed to have bread on this consistency. That's been a big issue. So on easy to chew, they can have soft sandwiches and they can have bread, but not toast. Now we've got, so we've got the regular meal here, which was rissoles, veggies and pasta. So that's fine for a normal diet. Now we'll go, so we didn't actually get an easy to chew one, but that's fairly close. You just have to be able to cut the meat sort of with a fork, be able to, cut through the meat with the fork. Next one is the soft and bite-sized diet, or level 6. Should be soft, tender and moist with no liquid dripping from the food. And the food should only be 1.5 centimetres by 1.5 centimetres, so no bigger than about your thumbnail. So quite small. And that makes the perfect size. And the pudding, the cakes cut up into those.
Cut up in that size.
Nice small sizes as well. So they shouldn't have to bite anything off, it should just be the right size to pop straight into their mouth.
That's not suitable.
No, so that's for, that could be easy to chew or normal, that cake. On soft and bite-sized, bread's not allowed. So that's the big difference between soft and bite-sized and the easy to chew. Minced and moist, level 5, includes foods that are soft, moist and easily formed into a ball. Can't contain any hard or sharp lumps. Should be easily mashed down, and they should be no bigger than 0.4 of a centimetre. So you should be able to fit the pieces of a minced and moist diet through the prongs of a fork. That's how small and fine it has to be. So yeah, so if we squashed it down, yeah, so they would go through it. Some of them are just a little bit sticky. They might need a little bit more gravy moisture. Not too much gravy though, as we were saying, if they're on thickened fluids, they can't have it swimming in gravy because then they're having, so that gravy there would be good for if they were on mildly thick, but probably too thin for moderately thick or extremely thick residents. And with the minced and moist, they should just be able to squash it down with their tongue. They shouldn't really need to be able to chew it, just a little bit of chewing required. Pureed foods, they should be smooth and lump-free, moist and cohesive.
Sorry about the look, we used it earlier.
Yeah, to hold their shape on a spoon, but it should also be able to lob off the spoon in a single lob, which again, we probably need a little bit more moisture. Yeah.
There is a thing too that it comes off easier if it's served hot. Because
Yeah,
this
this
is
is
sitting cold, it's
Yes.
a little bit more sticky.
That's been sitting there for an hour and a half probably, so yeah. And then the desserts for the minced and the moist and the puree are pretty much the same, so just smooth, no lumps for the puree. We just have to be careful again that the custard's thick enough for the people who are on the moderately thick or extremely thick fluids. Fluid consistency, so thin fluids, there's no alteration needed for anything at all. The mildly thick fluids are the level 2 with the pink stripe across the lid, and they're like a nectar consistency. Now, people who are on anything from mildly thick fluids up to extremely thick can't have jelly or ice cream because once it stays in the mouth, if they hold it for too long, it does turn back into a normal liquid. So they need to have the Screamies ice cream that never melts. So it can stay out all day and it just doesn't melt. What's that?
You can make your own, but it just takes a little time.
And with what?
Custard, ice cream.
Oh, okay. Right, okay. Much harder. Now there is a test, so we're looking into, because a lot of the carers have said we're not allowed to make up the drinks, like if someone wants tea or coffee, they're not allowed to make up the drinks. It has to be a nurse to make it up, and they're just not available when it's needed. So I think they're looking into what may be able to be done about that. But if we are making it up, that's the 200 mils, so it's just below that little marked line there. And for the mildly thick, you just have the smallest teaspoon. Always stir first before you add it, otherwise it goes lumpy, so that helps it to stop forming lumps. And we were saying they do have the thickened tea and coffee already made up, but most people hate the taste of it. So that's where we're trying to look into whether we can get carers to be able to make up the thickened fluid.
Yeah, we used to, and there used to be the liquid one as well.
Yes.
That you could use.
Yeah, I was talking about that earlier. Yeah, the precise one, yeah. The only thing is it often goes quite thick once you've left it there. Yeah, it mixes easily, but then
The powder takes a while to thicken.
yeah. So
The
we'll do that
liquid
with
takes a short time to thicken, but if it stands for a period of time, it thickens further.
So that's the one that we made up earlier, so it's staying with the right sort of consistency. If it does come to the day that you are allowed to make them up, there's a test that you can use with a 10 ml syringe to see that you've got the right consistency for everything. So with the mildly thick drinks,
But just one thing, it's got to be a lower tip. It can't be a lower lock tip. It's too tight. Okay, so you're going to do this.
so we just fill it up with 10 mils of the thickened drink. And then in 10 seconds, there should be 4 to 8 millimetres left in the syringe, and that shows you it's the right consistency for mildly thick. So we'll start now. Let it drip out for 10 seconds. Stop. And we have about 7 mils left, so that's perfect. So between that 4 and 8 mils. Then the moderately thick, we want no less than 8 mils left in there. So we'll just rinse that one out. Start. So it's dripping a lot more slowly than the mildly thick one. Stop. And there it is. Gosh, 9 mils left in that one, I think. So, hang on, is that right?
Yeah.
Yeah. Yeah. And then with the extremely thick fluids, we actually use a spoon test. So you put it on the spoon, it should blow off in one whole blob, just like that. So no dripping, just one huge blob, basically. So with the mildly thick and the moderately thick, you can drink them both from the cup. Mildly thick's reasonably easy to drink through a straw. Moderately thick, a slightly thicker straw is usually better. But the extremely thick is pretty much from a spoon, too hard to suck up through a straw. We also have to be careful with mixed consistencies. So if people are on thickened fluids, they shouldn't be having just like cereal and milk, because or soups that have got chunks in it, because you've got a liquid plus a solid, and that's much harder to control and manage and coordinate than if it's all just one consistency. Which is why we also give people tablets with yogurt or something thicker. Again, you've got a solid tablet with a liquid, and it's harder to control the two together, so it's easier going with something thicker for medications. Got any questions so far?
Do we know what size a mug is? Like the mugs that they have? The big
No,
mugs?
so that would have to be
So
measured.
that's where we're going to, yeah.
That's where it's going to be, yeah.
Because there's
So-
more than a cup.
Yes, yeah, and that's like the 200 mils there, so the mugs would probably be bigger than that, I would think.
Yeah.
Again, yeah. So, you know, if that came to it, we'd have to get, you know, the consistency with how big they are. You know, maybe have measuring jugs or something on each, in each area. Now, what does it feel like to have dysphagia? So I want you all, pass these lollies around. So what I want you to do once you've got your lolly is try to chew it without using your tongue at all. So,
Put it in my mouth.
yeah, exactly. So these people, you know, I've seen people with motor neurone disease who can't move their tongue at all, sort of sideways, any which way. So you can just see how much your tongue is actually involved in moving the food around in your mouth. And then the back of your tongue is also really important because it propels back and pushes the food down. So if they've got weak tongue muscles, they're having trouble pushing that food down. Often they might need a little drink in between to help push it down. So that just shows how much your tongue is very important in eating. The other thing would be to try is to have a drink of the thickened fluids, keep your lips open and try to swallow. So you know you're going to get spillage, and you need that little bit of closure to try and help with your swallow as well. Okay? You can't do it, no. Or feed somebody else a drink from the cup, which is what we're doing to people all the time. So, and when you are giving it to them from the cup, you always try and just give them one mouthful, pull the cup away and stop so they've got time. Some people need 2 swallows, 3 swallows to clear effectively. So don't just hold it up and let them drink continuously, always bring it back down after each mouthful, let them swallow and give them some more. Yes, that's enough. So when I do the assessment, I check their swallowing with the fluids. So if they're coughing on thin fluids, then we go to mildly thick, moderately thick, extremely thick, whatever it might be. Same with the food, so we use different consistencies to check. So sandwiches, toast, softer foods such as banana or diced fruits, or yogurt and puree. Change their diet accordingly. And then we're going to talk about positioning during and after meals as well. So when you're feeding the patient, you make sure they're completely...
Listen up, please.
Thank you. Make sure they're completely upright. I know some people have back pain or some issues where they can't sit up completely straight, but have them as straight as you possibly can. Don't let them tilt their head backwards because that opens their airway, so there's more chance of them aspirating if their head is tilted back. So if they're holding the drink themselves and they tip at the bottom of the cup or the bottom of the bottle, try and get them to bring their head back to level or slightly down before they swallow. Using a teaspoon or a dessert spoon if you need to, but don't overfill the spoon. So we don't want a big, massive spoonful that they're going to struggle to manoeuvre around the middle. So that would be too much for someone. So that's where, and if yeah, so that's good enough.
What a teaspoon here.
What did I say then? Oh, people who are very impulsive with their eating, some of them just shovel the food in. They're good ones to try and give a teaspoon to, so that they're, they can still get a big amount on a teaspoon though, but it might slow them down a little bit if they're very impulsive. Make sure they've actually swallowed before you give them another mouthful, so watch for their Adam's apple there to lift up. I had a lady somewhere else the other day, and one mouthful of puree, she took at least 3 minutes to swallow it. And she was chewing, so it looked like she was making an effort to swallow. And the carer who was feeding her said to me, I would have actually given her more food before that time because she thought she'd swallowed, but she hadn't actually swallowed. So some people are incredibly slow with their eating, which I know, is really hard for you guys when you've got to feed a whole group of people. But if you can just make sure they have swallowed first. If they are holding the food in their mouth, you can verbally prompt them, but again, that often doesn't work. If you put the spoon back into their mouth and apply some light pressure onto the centre of their tongue, that can sometimes trigger the swallow, just that little bit of pressure. Sometimes massaging under here can help. Occasionally I'll put just a tiny bit of thickened fluid on the tip of the teaspoon and put it in, and just that feeling of having a little bit more in their mouth can sometimes prompt them to swallow as well. If anyone's coughing, clearing their throat or choking, obviously just continue for that meal and let the RN know. If we can check the patient's mouth after the meals again to make sure they're not putting stuff in their cheeks, and then they're not going and lying down and aspirating on it. So it's just going through the pureed food, so it shouldn't be too sticky, doesn't require chewing, no lumps, and again falls off the spoon in one big lump. And again, they're just saying there up the top to watch out for the mixed thin and thick textures, so soup with pieces of food, cereal with milk. The minced and moist, we were saying, so it should fit between the prongs of the fork. They're saying rice. I wouldn't be giving normal rice to people on a soft minced and moist diet, but we do have creamed rice pudding here, which would be suitable for them. So, very wet, sort of sticks together. So that sort of consistency is fine for those people. Soft and bite size, as we said, it has to be, the 1.5 centimetres. What have I done here?
Going backwards.
Yeah. Yeah, soft and bite size has to be the 1.5 centimetre spoon food. They shouldn't have to bite a piece of anything, it all should just be ready to go and ready for them to eat. We have to avoid any foods. Sorry. And the soft and bite size, you should be able to push a fork down onto it. Your thumb should blanch white, and it shouldn't come back up to shape, so it should stay squashed down. So we did that with the rissoles that were cut up, and they stay squashed, so that's a good consistency there. We avoid any hard, fibrous foods like pineapple, rhubarb, that type of thing, anything with a skin like grapes, and beans can also be a big issue there. With the easy to chew, again, it doesn't have to be a certain size, so those rissoles are fine like they are. But again, avoid those sort of more fibrous foods and avoid things like salads, so lettuce, salad leaves, because they can be a big choking risk as well. Regular chew, easy to chew, allowed to have bread, as I said, with just fairly soft fillings. Sorry?
Test it with the fork.
Testing, yep.
So it just breaks away.
Yeah, so you're able to break it with the fork, pick it up.
You don't
So-
need a knife.
Yeah, so you can do it with the side of the spoon or with a fork to break up the pieces of meat or veggies, whatever
So
they
you
might,
don't need a knife.
whatever they might be. And the regular diets, just as I said, anything mildly thick drinks we've been through, the moderately thick and the extremely thick. Does anybody have any questions at all? No? Another one just to be careful of is dentures, because people can actually swallow their dentures. So I don't know, is there any rule that you don't have them in at night or anything like that? Yeah. So I had a patient in another nursing home, he swallowed them, they got stuck, they had to operate, he had a massive stroke and ended up dying. So yeah, can end badly. So you wouldn't think they'd be able to get them down yet if they can. So watching out for that as well. And loose fitting dentures are another big problem. Some of them are just wobbling around when you're talking or trying to eat, you can hear them cluttering around. Yeah. Oh, the other thing is, which Linda's also going to discuss, but if a patient doesn't want to be on a modified diet or liquid consistency, if they've got capacity, they do have the right to sign that dignity of risk waiver form. If they don't have capability, then it has to be their next of kin or their EPOA. I just have to explain to them. Oh, sorry. Yes.
Regarding to the amount of time we have to spend on feeding, just want to know the time frame, which is still beneficial or non-beneficial for how we sit in there.
Linda, would that be more you?
Look, it really depends on the resident, because obviously I'll be talking about malnutrition. We need to try and keep the amount of calories and nutrition into them. So it just depends on what they've been eating throughout the day, because there are some meals where residents just won't eat, and then there's other meals where they eat really well. For example,
Just keep going if you keep going. Yeah. Because like that lady I saw, she could take a good 45 minutes to an hour to be fed if she's just having that, one swallow in 3 minutes. So and I know that time is really, hard to give when there's a whole lot of people there. Yeah, so they're signing the dignity of risk. They just have to make them aware that there's the risk of choking, aspiration pneumonia, or possible death from choking, which isn't a pleasant way to go. So.
There's actually statistics that says from the coroner's court that 8 out of 10 deaths in nursing homes, we're only talking nursing homes, are a result of choking. You may be wondering why you've been asked to come and listen to the texture modified foods and drinks. And if you need to further your education, the IDDSI website, IDDSI.org, has got videos and all sorts of things that can help you to enhance your knowledge of texture modified foods and thickened fluids. But the reason that it's really important is because you've just had an Epicure audit done, and in that audit, this was the result. 39% of residents are on texture modified foods here at Victoria Point. Okay, so that's quite a large number of people that are on texture modified foods. 20% of residents are on thickened fluids. So it's really up to us to make sure that they do get to eat the right types of food and to eat sufficient amounts of that food. So those graphs are showing you, so they're the abbreviations. PU4 is puree, MM5 is minced and moist, SB6 is soft and bite size, EC7 is easy to chew 7, and RG7, we call it normal diets here. Okay. So you can see that the yellow is people who are nourished, the grey is people who are moderately malnourished, and the black is people who are malnourished. So you can see from those graphs that the more you decrease the texture, as in you go towards the puree diet, the higher the rate of malnutrition is. Does that make sense? Yes. So it's really, really, like it's sobering thought. We need to be able to spend a bit more time and put a lot more consideration into the texture modified diets so that we can change the statistics. All right. And a lot of the testing that they did when they were on site was to do with the correct consistency of the textures, which we're still working on, but hopefully will be fine. But it also means that you need to be aware of the right textures and what you can do. If you just go along to a Minster Moist and just throw on a whole lot of gravy, was that person on thickened fluids? Is that gravy suitable for thickened fluids? Does that gravy make that Minster Moist diet more sticky? They're the sorts of considerations. Plus, is it tasty? Does it look good? They're all things that you need to sort of be aware of and try to tailor to each of the individual resident. So, malnutrition is reasonably high.
Attention all staff, attention all staff. Could Mitch Bell, Mara, please come to reception? Mitch Bell, Mara, please come to reception. MJ, please come to reception.
Thank you. So, this is what. Well, you may be aware that the aged care standards will be changed on July the 1st next year, and there's one whole standard that will be devoted to food and nutrition. So the Commission has already put out some documents, which is one of those handouts, which outlines what they're expecting each facility to be doing. And the first one is to make sure that the person is appropriately assessed for dysphagia. So that means that if you notice any of your residents having some of those issues like coughing, difficulty swallowing, that sort of thing, they need to be assessed by a speech pathologist, and then the appropriate diet needs to be offered to that person. Does that make sense? Yeah. Then it's up to us to try and make sure that the diet is prepared. Oops, did I do that? Oh yeah. That is prepared correctly to the right textures. So if you find that it's too sticky or not suitable, then we need to do something to change that so that it is appropriate for the resident. Okay? The other thing is that meals obviously have to be appetising, and I think we've sort of started to do that by the presentation with the moulding and things like that. But it's now up to you as carers to try and get the residents to eat the food. And you need to take into consideration the taste of the food. You need to take into consideration whether that's appropriate and part of the resident's preference. So if they don't like fish, they shouldn't be given fish. Right? If they're vegetarian, they should be given a vegetarian meal. So that's the first thing, is that they get the appropriate food. The second thing is, do you like your food hot when you serve it, when you served it at a restaurant? It tastes better when it's hot, doesn't it? If hot food is served hot, then it's a much more tasty option. So be considerate. If you're going to be doing several feeds, sorry, I shouldn't use that word, assistance with eating, it's important that you offer them hot meals. Okay, so if it's been sitting on a tray for a couple of hours, well, I'm exaggerating. If it's been sitting on a tray for a little while and the temperature drops, it's not going to be appealing. It doesn't matter what texture it is. So be mindful of trying to keep that food hot. And if it's cold dessert, like ice cream, for example, make sure it's served cold, not at room temperature, where it's half melting. Yeah. The other thing to be aware of is if they don't like the taste of the food, and that's a common complaint, then try and use condiments that they might like Worcestershire sauce barbecue sauce, tomato sauce, salt and pepper. Those are the sorts of things that they would like to enhance the taste. The other thing is, if they constantly report the food is not tasty, you taste it yourself. Alright? Just take a teaspoon. See what you think. Quite often, I can guarantee a lot of this food is really tasty. Okay? And try not to offer too much sauces or gravy. If the person doesn't like sauce or gravy and you cover it with sauce and gravy, that's the end of their meal. They're not going to have it. So be mindful of what the person likes, what their preferences is. The other thing is to fortify where possible to maximise intake. When people go on to modified textures, they quite often eat less because every swallow is an effort. So they're going to tire very easily, especially if they're a bit malnourished. So it's really important to try and fortify the food where possible so that you're giving the maximum amount of calories per teaspoon or spoonful of food. So things like adding extra butter or adding extra cream. So you could serve a dessert that has got cream custard and ice cream on it. Okay? You can do extra yogurt, extra cheeses, but make sure that they have that. If they don't eat the whole meal, then sometimes eating smaller and often is helpful. So make sure that they get the mid-meals as much as possible. Now this one is the biggie. This is the one that the Commission really focuses on, and that's resident consultation. It's really, really important that you consult your resident all the time. Even if they say they normally just want a cup of tea, you still need to ask, would you like a cup of tea or some other drink today? Because you never know. One day they might want something different. Okay, so you need to consult them on their food and fluids and make sure that they get their choices and try not to guess. It's too easy to do that when you're trying to rush through things. And this was what Helen was talking about before, dignity of choice. There's always going to be residents who just do not want to be on the recommended texture or on that thickened fluid. So that needs to go back to the speech pathologist and they need to have a discussion about risk. And that needs to be documented. Now, one of the big drawbacks is that they do lose weight and they do become malnourished if they're on the wrong texture. Because you think about it, if they're having difficulty swallowing, they're just going to keep pushing food aside and not eating. Okay? So it's up to all of us to make sure that they enjoy their meals, keep prompting, keep doing as much as we possibly can to try and get them to eat as much as possible. And the last thing that the Commissioner looks for is ongoing monitoring. So, you know, we've already said that malnutrition is a major issue. Dehydration is another issue, and especially coming up to summer. Okay. There's a really big push in Queensland Health on delirium. They've now got evidence to show that delirium is a result of lack of fluid. Okay. So with the hotter weather, it's really important to push fluids on those that are not on the fluid restriction. And the second thing is if they are on thickened fluids, they probably need more attention on the fluids and to encourage them to drink that fluid. Okay. Are there any questions?
I want to know if someone signed a waiver saying they can eat, does that show on our current drinks list? Does it show on the list?
Yes, it does say risk waiver sign around.
Oh, okay.
You don't call it a dignity of choice anymore, do you? You call it something else. Risk waiver. Sorry, it's just at different places.
Risk waivers and dignity of choice. You
Got
need
both.
a dignity of choice for a risk waiver.
They're different, are they, Sarah?
risk waiver is signing that they acknowledge the risk, and that's the resident or the EPOAs, and then the dignity of choice is that they choose to make that risk.
Right, there you go. Thank you. Any other questions? Thank you.
Thank you.